Hi everybody, I'm Dr. Tim Dunne with Advocate Integrative Medicine. We've been in business for about 2 years now, and there's something that we wanted to share with you that we thought would give you a great deal of content and something that you would like to know as well. And that is, what happens when patients come in with the medical staff? What happens with our conversations? How do we communicate? And how do we come up with a care plan that best fits you? We have a unique model that we're using where we incorporate medical doctors, nurse practitioners, chiropractors, and rehab technicians in order to deliver the health care, and more importantly, in order for us to communicate on a regular and often daily basis in order to treat you as you come in the door. So once again, we started this about 2 years ago, Dr. Cindy and I. And on our medical staff, I am so grateful and so blessed. We have Dr. Matt Riggins with us. Dr. Matt is our medical director. He's our oversight. He basically keeps us all in line. He's the one that we can refer to with our great pool of wisdom whenever we have needs. Also with us is Dr. Holly Dockery. She has a doctorate as a nurse practitioner. And then most of you know me, I'm Dr. Tim Dunne, I'm the chiropractor of the group. So what we wanted to give you here today is in essence a fireside chat. How did we get to this point? And what would you like to know as consumers or patients? So most of us would probably want to know, how does this arrangement benefit you? How does it benefit you from a time perspective, from a communication perspective, and most importantly, from an outcome perspective? So here we go, folks. I hope you enjoy. We sure enjoy these things. So, Dr. Riggins, you've been a medical doctor for a few decades.
A few decades, yes.
A few decades.
Yes.
What was your specialty?
After medical school, I performed a residency in family medicine locally, actually, at East Tennessee State University, becoming board certified in family medicine and have maintained certification in family medicine since 1989.
Wonderful, wonderful. I met Dr. Riggins and his wife when we first moved down here. Gosh, that was 9 years ago. He and his wife had a horse farm, and our youngest daughter is an equestrian. So that's how we got to know each other and shared a lot of interesting times. So how many years have you been taking care of folks?
Well, graduating medical school in 1986, finishing residency in 1989. After a brief stint in Pennsylvania, I have returned to the area in 1991, continuing patient care for, oh my goodness, that's 30 years. It's 30
Wow.
years now in this area alone, 32 years if you count the time I was out of the area. So,
Okay.
quite a bit
So
of experience.
you've seen a lot.
Seen a lot over the years, yes.
Yes. We've always chuckled and thought, you know, your first 5 years, you're just cutting your teeth. Once you've hit that 10-year mark, you've started to see just about all there is to see. And after 25 years, things start to come back.
It is interesting to see the changes in medicine that have happened. We've gone from the symptom-based acute care model to more of the preventive medicine, rehabilitation, prehab is another way of also of thinking of that also.
Excellent.
But even in all the years of practice, you never see everything. There is always something that is new on the horizon that makes you think, and it also reminds you why you went into healthcare in the beginning.
Yes, yes. So Dr. Dockery, how long have you been in practice? What is your background?
Yeah, so I started out as a bedside nurse in acute care in the hospital after graduating nursing school, and that was in 2010. Prior to that time, I worked as a nursing assistant, doing mostly assistant duties. During my time in nursing school, got out, started working in acute care in the hospital setting, doing critical care, really getting my skills down from a bedside clinical perspective. Then I decided to go on to graduate school, and I started in 2014 in a doctorate program, which at the time at ETSU was still relatively new. I was in the 4th cohort that they graduated. And so I graduated in 2017 with my Doctor of Nursing Practice degree, and I had chosen a not so common path where I focused on adult and geriatric primary care rather than family practice. So I was a little more specialized as far as the adult and older adult populations go. And then after that time, I began working in the post-acute care setting, which is sometimes thought of as a nursing home, long-term care, kind of caring for a range of people, including short-term rehab stays for hip replacements, knee replacements, that kind of thing, to people just living in long-term care who functionally cannot care for themselves, doing memory care, dementia care, psychiatric monitoring, and then also end-of-life hospice as well is kind of in that same setting. So, but then in that setting we also do a lot of acute care because the goal is to keep people out of the hospitals. So it was really a broad range of care experiences, primarily for older adults. So,
what made you interested in the older population? Because you're early on in your career.
Yeah, so when it came time for me to choose a track, it was kind of like, okay, one of the main differences between family practice and adult gero is children, babies. I never had any experience working with a pediatrics population, working with newborns, labor and delivery. That was the one thing I really never did in my bedside experience. So when I thought about it, it's like, well, do I really want to pursue caring for that population? Or do I want to be a little more specialized? I chose the route of adult gero because I was used to working with adults and that's what I wanted to do. Also, looking at a population perspective, baby boomers as a generation, as a population, are very large numbers, and they have care needs, a lot of chronic diseases.
Yes.
And so I thought it was really interesting at the time I was at in my career to be able to focus on that population because there is an immediate need for specialized care for that population. And there's a lack of care, not just in our community, but nationwide. In America, there's not a lot of providers that are specialized to care for old help, and we can offer that here, and that's really cool.
I think it's interesting that you point that out because people today are not looking for necessarily a medication to solve a problem.
Right.
And the rehab portion, the prevention portion, the training of muscles to prevent injuries from occurring in the first place is a great emphasis, I believe. And obviously with people getting older, we do have to be cautious of what goes into our bodies, and the model that is established here is an excellent model to put that forward.
And how do you compare that to what you've seen with your experience? What was it like then? How do you see it now, and how do you see that translating forward then, Don?
It's interesting to see over the past quarter of a century plus the emphasis that has been placed upon prevention. The phrase, an ounce of prevention is worth a pound of cure, has become more obvious over time. Also, the number of medications that people consumed in the past, the benefits have been shown not to be as beneficial as we thought. Therefore, the push towards the strengthening of muscles surrounding a joint rather than just focusing upon a joint itself, for example.
Okay.
So I think that is a great emphasis. Seeing somebody in the acute setting, what is it that caused this injury? How can we address this to keep this from happening again? Through simple methods can be done at home.
Right. And a lot of that just comes back to education. But in order to be able to reach those people and those patients to educate them, we've got to make contact with them. And so it's nice to have a facility where someone might be coming in either for primary care, or maybe a acute symptomatic complaint, or for preventive chiropractic care. There's a whole host of issues why someone might present to our practice, and it's nice that then we get the opportunity to make contact with them and see what they really need.
So one of the things that I've seen throughout the years is patients come in, patients come out, and they haven't changed. So how do you see that as being different, Dr. Holly? How do you see that as being, one, patient's desires? Do they desire something different than what they've desired before? In the past, it's always been just symptom relief. Do they desire something different? What are we giving them that is different? And is this a typical doctor visit?
I think that's a really interesting question, and the first thing that kind of comes to my head is quality of life. I think a lot of people are realizing now more than ever that life truly is short and that we do have to appreciate each day that is given to us. And I think health is a huge part of that. Just overall health and wellness and feeling well to be able to engage in life in the way that you want to engage in it, if that makes sense. So coming here, if it is for prevention, if it is for immune support, if it is to make sure everything's in check, that's really important. And then if there is something wrong, then we can help guide you to a resolution or a way that maybe you can help yourself so that going forward you can achieve the quality of life that you want.
We use the word cause around here a lot. That's something that we find that needs to be the focal spot. And there was a term, and I'm going to let you throw it out, that we used the last time that we shot some videos, and that is engaging with a patient, having them assist in developing the care plan, and then them telling you what they're comfortable in doing, and that so you can guide them and kind of stretch them to get out of that comfort zone and to get something better.
Yeah, so we were talking about shared decision making and how no one's coming in here for me just to tell them what to do, because that doesn't promote good outcomes. I can tell anyone what to do, but one, that doesn't mean that's right for that patient. That's really just one person's opinion. There's a whole range of things we can do for any one person, and there's not necessarily one right way. And so that's where it's really cool to have multiple professionals and multiple disciplines come together and say, well, from my perspective, this is what's important to me and what I think we should do, but Dr. Riggins might have something else and you might have another thought. And then together we can communicate that with the patient and say, well, what does the patient even want and what's realistic for them? And that's where that shared decision making comes in. It's like we can all work together, talk to the patient, and come up with a plan of care that works for that patient.
So when the patient feels like they're part of that process, they've got some decision making in the game.
Yes.
We could use the phrase, you got skin in the game, but for them, they're the patient, so they've got it all in the game. But this is a way for them to be part of that process. And instead of them being an object that we're dictating to, we can pull them in to the circle and say, okay, what are you willing to do and what are you not willing to do? Because we're not going to spend time on things that you're not going to do.
Right.
We're going to focus on the small wins.
Well, and that's going to promote your good clinical outcomes, and that's going to promote patient satisfaction, which is
also
important.
going to promote better health in the long run.
Yes.
Exactly.
Yeah.
Yes.
We find that with this kind of model, we see the patients a little more often, at least through the chiropractic side, through the physical medicine side. We're seeing patients more often. And in doing so, we learn their families and where they work and their lifestyles. And we've always found that to be very beneficial, because if I know that you work at Snap-on, or if I know that you work at ETSU, or these other different jobs, I'm already looking at your lifestyle and how it's affecting your health. If we know you well enough to know what your hobbies are. So that is one of the huge benefits that we see with this kind of model. How is it different when a patient comes in? When a patient comes in, if they were typically going to see a family practice doc, or any of us, a chiropractor, PT, how is it different when a patient comes into this facility? How are they handled and managed in those first 3 or 4 visits that's different?
Well, usually they're starting out with me. And from my perspective, I'm kind of a one-stop shop. in the sense where you're not coming in and a medical assistant or CNA is first grabbing you and putting you in a room and initiating the exam. I'm the one picking you up out of the waiting room. You're coming with me, and then I'm initiating that visit from the very get-go. So that already is a huge difference. Similarly, you know, I'm going to be the one drawing your blood. I'm also doing your exam and your prescription. It's really hands-on with me from the beginning on that day one visit. And then at day one, between me and the patient, we're really getting to explore what your needs are, what kind of testing we need to do, and initiating that testing. And then when they come back on day two, then there's a group discussion. We get to sit down and we get to look at the x-rays, we get to look at labs, we get to look at the records, talk about what's going on and what we can offer, and then discuss that with the patient. So really from day one, it's very hands-on. There's not, I feel like, a lot of sitting back or talking. There's not a lot of transition among staff. It's really just hands-on with the people that you need to talk to from the moment you step in.
So the data's not lost.
Yeah, the line of communication is very clear. So.
Yes. And then between their first visit with Dr. Holly and their second visit, then we all sit down.
Yeah.
We all sit down. We sit down and discuss their diagnostics, their labs, their x-rays, any other diagnostics that come in, any other red flags or yellow flags that may present. We want to review those together as a team. We want to sit down with all of our departments, including the insurance department, the administrative department. What are all of our options that we can put on the table for this patient? Not just if they come in with low back pain, what else is going on? As a chiropractor, I appreciate being able to look at labs and discuss this with you ahead of time. And this is what I'm thinking. You know, what are their inflammatory markers doing? What are some of these other things that are going on? The type of x-rays that I order are standing, or I refer to those as functional x-rays, because we're loading the joint, we're loading the tissue as we're x-raying it. Because when you unload it, that joint will change. Versus when we load it and now we x-ray it, now we're seeing what that joint or that tissue is handling under the load. Much the same way, Dr. Riggins, that used to order stress tests.
Yes.
Because you want to see what the heart's doing under a load. My thought was, why aren't we doing that with all of our tissues?
I think that's very important, the way that you approach that with the viewing of x-rays as example. What is it like when the pain is occurring? What is happening to that? You can x-ray a joint and it'd be perfectly normal, but when you stress that joint, you may actually see what is causing the issue, what is causing the pain, what is causing the limitation of movement. So that also is something that I think is different from what traditional medicine has been taught in the past.
And this is really what our goal is. You know, Dr. Holly and I had this conversation yesterday with Dr. Cindy, and that yes, we've been in this type of model for 2 years. Dr. Cindy and I worked in this model for 8 years up in Toledo, Ohio. We worked with 37 different MDs, pain docs, physiatrists, general surgeons, so we were able to get pieces of information. And we thought we were fully prepared to open this and to launch this. But what we've really found now is that it's the staff. It's all of us coming together and saying, okay, this is your skill set. Now how can we mold this in a way that heightens the patient care? And that's what we've been able to do. So from our perspective, we really appreciate the two of you having patience with us so that we can continue to see what benefits patients the best. Critical things. So folks, we're going to wrap up this first and initial one. We appreciate you tuning in. We're going to have more to come. So if you would, let us know your feedback. Give us some questions on things that you would like us to talk about. It may be diabetes, it may be hypertension, it may be chronic diseases, it may be other different types of things that you're experiencing. You send us the questions, we'll write them down, because I think it would be fun to have a basket full of Q&A. You know, put us on the spot. Put us on the spot. Ask us those tough questions. And if this goes well, I would love to have where we have a setting with an audience, and the three of us, or if we can get Dr. Cindy involved, where we can get it right from the patient. Because that's what I like about this model. You get access to all of us. You get full access to us. Well, what's that lab going to tell us, Dr. Holly? What's that lab Dr. Riggins going to do to tell us on our patient care changes? So that's what we appreciate. Folks, I hope you enjoyed it, and we look forward to having this once again. I'm Dr. Tim Dunne with Advocate Integrative Medicine. Click, love, share. Let your family and friends know where we're at and what we're doing, because we're here to help you.